Hello again. I'm going to talk a little about the childhood adverse experiences on psychopathology and why screening is very important when seeing children in pediatric clinics. So adverse childhood experiences are traumatic and stressful events that overwhelm one's resource to cope. They have been categorized mainly based on the study into maltreatment, physical, emotional, sexual abuse, and physical and emotional neglect, and also dysfunctional family or household dysfunction, such as having a family member who is using substances or suffers from mental disorder. The study started in the 1970s and 1980s when in San Diego, when 50% of the patients in Kaiser obesity clinic were dropping up from the treatment despite being successful under the program. So they decided to interview patients to see why they leave the program, why being successful. And they realized that a good number of patients who drop out has suffered from childhood sexual abuse. And in fact, eating and gaining loose is a way of coping with the depression and anxiety that they were suffering from. So they expanded the study on 17,000 patients, and they realized a number of patients actually suffered from different kinds of maltreatment and adversity. So the main finding of a study was that ACEs are actually very common. ACEs often occur together. They are not isolated events, and one who suffers from one type is likely to suffer from other types. And ACEs have a dose-response relationship with many health outcomes. If somebody has experienced more types, they are more likely to show worse outcomes. And this study, followed by other studies, and they established a good relationship between ACEs and mental health and also other outcomes in patients and general population. In Canada, based on the study that recruited 23,000 individuals, adults in 10 provinces, people reported that like 1 in every 3 Canadians has experienced a type of child abuse, such as physical or sexual abuse in their life, and all types of child abuse were associated with all the mental health conditions they included in the study, such as depression or suicidal ideation or attempts, and a similar dose-response relationship was found in this study as well. These are the self-report, which we see that the number actually is very high. However, when the reported cases were included, like in Canadian incident study of reported child abuse and neglect, that included the reported cases to the child protection services and substantiated cases, they realized that the highest rate belongs to neglect, exposure to direct and indirect violence, physical abuse, followed by emotional maltreatment and sexual abuse. But usually the cases that get reported are harsh enough to grab public attention. They leave bruises or injuries or are visible by others. There are other types of maltreatment that are mostly neglected in both research and clinical setting, like emotional neglect, verbal abuse, witnessing domestic violence, and peer victimization during childhood and adolescence. But they are very important because they usually happen chronically, and some research shows that they have similar or even worse effects on brain and behavior and the development. So how ACEs actually result in psychopathology or mental health outcomes? Very briefly, I included some research, some sources, including our own review paper. But the thing is that ACEs affect the development. Brain is highly sensitive during childhood and adolescence, especially during early adolescence. And the biological mechanism there actually determine that in what ages environment can have an effect on the brain development. There are sensitive and critical periods that environment and adverse events and stress can have an impact on the brain regions. They increase the stress response system, glucocorticoid, through glucocorticoid receptors. I don't want to get to the details of this, but in general, they affect the normal maturation of the brain by altering the brain networks and brain regions. And through that result in different cognitive impairments such as low inhibitory control over the behavior, loss of inattention, and other impairments that can, and also problem with the mood and with affective disorders that can all result in psychopathology. The most vulnerable brain regions that can be affected by the by ACEs and maltreatment are amygdala, hippocampus, cerebellum, corpus callosum, hemispheric integration, and importantly, prefrontal cortex. Prefrontal cortex continues to develop into late adolescent and early adulthood, so they can be highly sensitive and they can be highly, this area can highly be affected by the effect of stress and adversity. Beside the psychopathology, ACE is also related to the lower life expectancy, academic failures, and many other problems. In addition to the psychopathology that has been studied in many studies, ACEs also are related to a wide range of symptoms. Maltreated children are more likely to lose their controls over their behaviors, show impulsive behaviors, lose their focus and attention when they are expecting the next violation of their safety happens, or shift from one mood to another mood, and the list goes on. A lot of symptoms actually appears in these kids. But why attention to ACEs are important in clinical setting and also in research, especially working with in pediatric settings? One important thing is that because ACEs has a high burden on psychopathology, those who are exposed to any types of ACEs are more likely to show different types of psychopathology. These are just some examples of the rates. And also, in those who are exposed to ACEs, when disorders appear, they emerge earlier, with a greater severity and more comorbidity and a less favorable response to treatment. Even recently, there have been many efforts to add subtypes to the diagnosis of DSM for some disorders like substance use, depression, anxiety, for depression with child maltreatment, because these people need a specific treatment for their problems. One thing that I want to talk a little about is that ACEs can overshadow diagnosis. I will go to this with more details. A good example is ADHD. Because there is no clear evidence that ACEs or chronic stress cause ADHD. And it's very common in pediatric setting. There is an estimation that in the US, nearly 1 million children misdiagnosed with ADHD every year. So there have been studies to realize who is more likely to get the diagnosis of ADHD. Different studies have showed that children with coming from low-income families with socioeconomic disadvantages, those who have been exposed to ACEs and violence, are more likely to be diagnosed with ADHD. And so the usual symptoms for the ADHD that are inattentiveness, impulsivity, and hyperactivity mirror adversity effect. The problem can be with the medication that are usually used for treating ADHD, which is often a stimulant. And we don't know how they affect a maltreated children that is already hypervigilant or agitated because of their experience. And also, the behavioral treatment for ADHD children are focused on organizational skill or time management that are basically ineffective for maltreated children. So it's very important, but it's usually very hard to tell the difference that when we are actually diagnosing ADHD truly, or it's just a maltreated children that is showing similar symptoms. The solution might be to look at the problem in a more holistic and comprehensive approach. And when trying to diagnose a kid or plan a treatment, look at different kinds of and different aspects of the problem. Maltreatment can amplify the biological vulnerability that some children have and predispose them to the psychopathology. And also, we should see that all aspects, including the parents, the family environment, community, school, and everything can affect children that is still developing. I would like to share a result of one of our studies here. We were looking to see that how the environment and actually our experiences can affect the relationship between something that is a kind of biological and a behavior, a maladaptive behavior. So we were interested to see if adolescents who have lower control over their behavior, who show poor inhibitory control, which is an executive function essential for many aspects of our lives to actually inhibit unwanted and impulsive behavior, show more aggressive behavior at baseline and over time. So we recruited, actually it's part of a bigger study, but 3,800 adolescents were assessed at baseline when they were at grade 7, around 12 years old, and followed for 4 years to see if those who have lower level of inhibitory control over their responses are more likely to show aggressive behavior toward peers. And yes, the relationship was positive. They are more likely to show aggressive behavior. But interestingly, this relationship was mediated by victimization. So for these impulsive kids to become aggressive, they have to be victimized first. And it's very important because this aggressive behavior, we just see the aggressive behavior, but it's different from the aggressive behaviors that is goal-oriented or for the purpose of dominating the peer group. And so it needs a different kind of attention. So these findings have very important implications for clinical practice and for research. First of all, experiences early in life can have a persistent long-term impact on physical and mental health, as we said. And early intervention matters because getting things right earlier is easier and more effective than trying to fix them later. A result from a 45 years longitudinal study in Britain shows that most of the negative outcomes related to the experience of adversity doesn't disappear or even reduced over time. So people have to live with these outcomes over their life. And highly specialized intervention are needed as early as possible for children experiences ACEs or toxic stress. These children may not be responsive or to the usual treatment, or they may need a specific treatment to address their needs and outcomes. And all of society benefits from investment in early childhood programs. Some research shows that with every $1 invested in early programs for vulnerable kids, $4 to $9 return to the society by different ways, through lower rates of criminal activity, through increased tax revenues, and less need to invest in specialized education for children. One important thing that is highly used everywhere is the trauma-informed practice. I think everyone is familiar with that. It's the organization or treatment intervention that focuses on how trauma or ACEs may affect an individual's life and response to services, to the treatment, and realize the high prevalence of trauma and ACEs, realize the relationship, and also put it into the practice and recognize the trauma and ACEs exposure at all levels, including its own workforces. As we know, the rate of compassion fatigue and burnout is very high in people who provide services to children and people with mental health problems. In special, it's important to screen for the ACEs in children and adolescents as early as possible, but it's important to have a universal precaution. We know that the rate is very high in vulnerable children and in pediatric settings, so we can kind of assume that everyone might have experienced some kind of adversity in life. And it's not always possible or appropriate to screen for ACEs, especially at the beginning, but we have to do our best. And a child may actually withhold a neglect or abuse to protect their family, or even the family themselves do that because of the mandatory law or other things that may put them in problem, in danger. And some cultures or backgrounds may even normalize some types of maltreatment, and people even don't see that it can be this behavior can be a maltreatment or adversity for their kids. We may not see it, but we have to keep an open eye for it throughout the treatment. And also, clinicians and care providers should be universally attentive to the ACEs and trauma when providing services to the vulnerable children. In addition, for diagnosis and treatment planning, it's very important to screen for ACEs because it can prevent misdiagnosis, as we talked earlier, and it can help the treatment planning, and also it can prevent these clients to drop out from the treatment. It can help them to engage better in treatment, and also it's kind of a prevention strategy because it prevents children from developing more severe problems. There are factors that influence the screening and assessment of ACEs. I don't have time to go to the details of every one of these, but there is a good resource to read if you want to know more about the details of this. But in general, what is important is how to approach a screening for ACEs. Families should know that why we are doing this, why it's important that we do this screening, and why it's important to know know the ACEs or maltreatment that their children have experienced. It's good to explain for them about the treatment planning and everything. So I would like to thank you and thank the chair and also St. Justine Hospital for providing the postdoc fellowship for me. Thank you. I would be happy to get some questions. Thank you.